Hi, my name is Henry, and for my BioChem 3D03 Your Way assignment, I will be focusing on fat metabolism, specifically the role of acylcarnitines and its implications in diabetes, insulin sensitivity, and weight loss. Before I begin, I want to talk a little bit about what fatty acid oxidation and fat synthesis is. So specifically for fatty acid oxidation, also known as beta oxidation, it first happens with the release of free fatty acids from triacylglycerols in adipocytes by an enzyme called hormone-sensitive lipase. These free fatty acids will then be released into the bloodstream complexed with albumin because they're not soluble within the blood and delivered into our muscles or our liver cells. From there, these fatty acids need to be activated by CoA by using an enzyme called acyl-CoA synthetases to produce acyl-CoA. There are three acyl-CoA synthetases, and they're specific for long, medium, and short-chain free fatty acids. We have learned in class that beta oxidation happens specifically in the mitochondria, but there's no transporter for acyl-CoA from the cytosol into the matrix. So, carnitine in the cytosol actually picks up that acyl group and shuttles it into the mitochondrial matrix through the carnitine carrier protein. And this is catalyzed by this first enzyme, carnitine palmitoyltransferase 1. CPT2 then catalyzes the conversions of acylcarnitines back into free carnitine and acyl-CoA. So this is just a summary of fatty acid oxidation and fat synthesis. I highlighted the first three steps of beta oxidation. From there, we have acyl-CoA that's in the matrix. It will undergo beta oxidation to create acetyl-CoA. This acetyl-CoA can then feed into the TCA cycle and generate ATP if our body is in need of energy. Or it could be converted into citrate and it could leave the mitochondria to the cytoplasm through the tricarboxylate transport system. This citrate can then be converted back into acyl-CoA in the cytoplasm by ATP citrate lyase, and then through two enzymes that catalyze 8 reactions, ACC and fatty acid synthase, we will synthesize our fatty acid palmitate and only palmitate. So before we dive into different studies, there are some things to keep in mind. A study done by Costel et al. Showed that carnitine concentrations actually decreases with age in mice. Additionally, another study showed that the rate of glucose oxidation and plasma carnitine levels were actually lower in people with impaired fasting glucose, also called prediabetes, that when paired with impaired glucose tolerance can be a sign of insulin resistance, and it is also lower in patients with type 2 diabetes as well. First, we will look at how exercise affects our plasma levels. Researchers in this study wanted to assess the correlation of acylcarnitines with mainly energy expenditure and insulin sensitivity during and before a weight loss intervention in obese subjects. So in this study, 60 obese subjects were recruited with no history of type 2 diabetes or childhood obesity or bariatric surgery, and they were assigned to one of three 12-week interventions. The first being a hypocaloric diet of about 600 calories a day. The next is the same diet, but with some moderate exercise, around 10% of daily expenditure. And the third is with a weight loss drug with the same diet as well. They then measured these subjects at 0, 4, and 12 weeks after an overnight fast and collected some blood samples. This is just a table of the clinical characteristics at day 0. Here we can see that the participants had slightly impaired fasting plasma glucose levels. The normal range is actually between 3.9 to 5.6 millimoles per liter. And there's also an elevated homeostatic model assessment for insulin resistance, or HOMA-IR. This is just a rough measurement of insulin resistance, and the lower the better. It is said that an optimal HOMA-IR is less than 1. If your HOMA-IR is greater than 1.9, that could signal early insulin resistance, and greater than 2.9 means that you are insulin resistant. So these participants here who are obese, right, had impaired glucose levels that are elevated, and also elevated HOMA-IR as well. Researchers did 2 correlation analyses. The first one is called a Spearman's correlation test, They found that plasma non-esterified fatty acids, or NEFAs, corresponded very strongly with certain species of carnitines, specifically C2, C4, C14, and C6 and C18 carnitines. The second multiple regression test found that C14 and C16 carnitines are strongly correlated with plasma NEFAs. This figure here shows the effect of weight loss for the entire group, irrespective of treatment allocation. We can see from day 0 to 28, weight decreased about 4.5 kilograms. BMI has also decreased, right, between day 0 to 28, but not really that additional improvement after 28 days. Specifically, HOMA-IR actually decreased quite well. This is actually an improvement. Their fasting plasma levels also decreased, but again, not after 28 days as observed. And fat mass actually decreased over time over the length of the entire study. This figure here shows the whole group plasma acylcarnitine levels for day 0, 28, and 84. In general, it is shown that weight loss increased carnitine levels. C2 and C4 carnitines were actually higher after 28 days, with no further increase after 28 days. But C14, C16, and C18, so this one, and this one, all showed a similar pattern, with an increase in carnitine levels after 28 days, but followed by a decrease in carnitine levels beyond 28 days at 84 days, but still higher than baseline. And when the researchers analyzed the data, they found that fatty acid levels, or NEFAs, corresponded very positively with levels of C16 carnitines. So, in summary, what does this study say? This study shows that with weight loss, there was an increase in plasma acylcarnitines in obese individuals, despite an improvement in insulin sensitivity that's measured by HOMA-IR. The increase in the different carnitines are indicative of a few things. First, C2 carnitine is only produced in lipid and carbohydrate metabolism. So the increase here suggests that lipids are being used as a primary source of energy. C16 and C18 carnitines come from our dietary palmitate and oleate, which is stored in our white adipose tissue. So this increase suggests that lipolysis is happening. C14 carnitine is only produced in beta oxidation, only produced after 2 rounds of beta oxidation, and thus it is a good marker for fatty acid oxidation. So we talked about acylcarnitines and its roles in exercise and insulin sensitivity, but what about type 2 diabetes? In this study, researchers wanted to know whether they can use acylcarnitines as a minimally invasive probe to identify if there are defects in fatty acid oxidations in individuals that are obese or have type 2 diabetes, compared to healthy individuals under fasting conditions and during an insulin clamp. An insulin clamp, or a euglycemic clamp, is a way to quantify specifically how sensitive the tissue is to insulin. Participants were put into 3 groups. The first group is lean, sedentary, with no history of diabetes, and with a normal glucose tolerance, measured by an oral glucose tolerance test. Second group is non-diabetic, obese individuals who were glucose intolerant. And the third group is obese individuals with type 2 diabetes. Researchers gave them a standardized diet composed of about 50% carbohydrates, 20% proteins, and 30% fat, put them on an insulin clamp after an overnight fast, and took plasma samples. So this table shows the clinical characteristics of the 3 groups at baseline and also during the insulin clamp. As we can see, people who are obese actually had a higher central adiposity over here. They have a lot more fat mass and body weight. Diabetic individuals also had way higher fasting glucose as well, right? This is because they are insulin resistant and they cannot uptake glucose into their cells. And also their glucose disposal during the insulin clamp was very, very low as well. Fasting fatty acid levels were also very high in obese and diabetic individuals, as we expect. In the plasma samples, they measured long-chain acylcarnitine levels, which were all elevated before and after the insulin clamp in obese and diabetic individuals. And similarly, they also measured short-chain acylcarnitine levels before and after the insulin clamp. And they showed that diabetic individuals actually had way higher levels of short-chain and medium-chain acylcarnitines. So what does this mean? Well, in simple terms, this research discusses how subtle changes in lipid metabolism occur in obesity and type 2 diabetes. Type 2 diabetics and obese participants had a similar accumulation of these long-chain acylcarnitines and also acylcarnitine species that arise from the activity in the initial rounds of beta oxidation, which is consistent with the increased flux at entry into the mitochondria for beta oxidation. Diabetics also had an accumulation of short-chain acylcarnitines, which actually suggests that there is an inefficiency in fatty acid oxidation or impaired interactions between beta oxidation and the electron transport chain. And this is why some researchers say that type 2 diabetics are quote-unquote metabolically inflexible. Therefore, these short-chain plasma carnitine levels that are accumulated in type 2 diabetics can actually be used as a great marker for glucotoxicity and type 2 diabetes. Finally, our last study looks at whether or not supplementing L-carnitine improves insulin sensitivity and what if it is actually paired with caloric restriction. So here, adult patients were recently diagnosed with impaired fasting glycemia, also known as prediabetes, or type 2 diabetes, were enrolled into the study. Participants were randomly put into two groups, one with a low-caloric diet composed of about 55% carbohydrates, 25% lipids, and 20% proteins, and another with the same diet, but in addition with 4 grams per day of oral L-carnitine. These participants were told not to change their lifestyle, and at the end of the study, they tested their glucose tolerance through an oral glucose tolerance test. They tested their plasma insulin levels, their HOMA-IR, as previously discussed, and this was assessed at the end of the study. So this graph here just shows the patient characteristics of the two groups at baseline. There are 8 groups in group C. There's 8 people in group C and also 8 in group LC. C represents just the diet, just the low hypocaloric diet, and LC is the hypocaloric diet in addition with the 4 grams per day of oral L-carnitine. At the end of the study, fasting plasma glucose levels were similar, and body weight also decreased, right, between the two groups. Both groups also showed a significant reduction in their oral glucose tolerance test in 2 hours when compared to baseline values, but the improvement in the LC group was a little bit more pronounced compared to the control group that just had the hypocaloric diet. However, what is very significant is that there was a significant reduction in HOMA-IR only in the LC group, those who took L-carnitine in addition with the hypocaloric diet, but not seen in the control group only with the hypocaloric diet. So in conclusion, they found that insulin sensitivity was enhanced by the supplementation of L-carnitine, as we saw that HOMA-IR decreased in the LC group. The biochemical mechanisms responsible for lower fatty acid oxidation involves a reduction in a reduced carnitine palmitoyl transferase activity, and as such, it is said that exogenous supplementation of carnitine may actually restore this deficit. Other in vitro studies by researchers also shown that L-carnitine deficits actually downregulates the mRNA expression of acylcarnitines, acyltransferases CPT1 and CPT2, and it is shown that L-carnitine supplementation actually reverses this downregulation and increases gene expression. So, in conclusion, what do we take away from each study? Well, in study 2, we saw that short chain isocarnitines can be indicative of inefficient fatty acid oxidation, and its accumulation of these short chain isocarnitines is a great biomarker for glucotoxicity and for type 2 diabetes. So, if we measure the levels of short chain isocarnitines in the blood, if they're elevated, that can be an indication that you might have a lot of glucotoxicity, because that isocarnitine can leave the mitochondria into the plasma, right? And that can be also a great indication of type 2 diabetes. In study 1, however, long chain plasma isocarnitines increased actually with weight loss, but this is not actually necessarily bad. Even though we saw short chain isocarnitines were elevated in type 2 diabetic patients, during exercise, long chain plasma isocarnitines were increased because you are undergoing more beta oxidation, right? So this is actually not necessarily bad, because researchers saw that they actually had better insulin sensitivity. Even though high plasma isocarnitines is seen as a hallmark of type 2 diabetes and insulin resistance, it might actually be just the short chain isocarnitines that is the main issue, because it is also indicative of inefficient fatty acid oxidation. In study 3, we saw that just with a hypocaloric diet, we can actually improve our glucose tolerance. Individuals had better oral glucose tolerance test, and that in addition with taking a 4-gram L-carnitine supplement, we can actually improve our insulin sensitivity in patients with type 2 diabetes. But why take a supplementation when you can just simply exercise, right? What we saw in study 2. So the overall takeaway message is that simply by following a weight loss regimen and with exercise, we can actually improve our insulin sensitivity and decrease our risk of diabetes. In clinical settings, however, patients with diabetes can explore taking L-carnitine supplementation to improve their insulin sensitivity levels, as we saw in study 3. But this should be further studied as well. And that's basically it. That wraps up the 3 different case studies. For accessibility, I have posted a copy of the lecture slides, the speaker notes, and there's also a summary sheet that will be provided that summarizes all the different cases and and the conclusions that we have concluded. Thank you so much for listening to my presentation.